As you mentioned, my name is Leigh Casadaban. I'm from University of Colorado, and today I'll be presenting on portal hypertension. Portal hypertension is a major cause of mortality other than hepatocellular carcinoma. It is also seen in decompensated cirrhotic patients. It leads to portal systemic collateral veins that cause variceal bleeding, ascites, and hepatic encephalopathy. Portal hypertension is defined as hepatic venous pressure gradient, HVPG, greater than 5 millimeters of mercury. HVPG is the difference between the wedged and the free hepatic venous pressures and used as a surrogate for the portal systemic pressure gradient. You should also know that clinically significant portal hypertension isn't really seen until you get a gradient greater than 10 millimeters of mercury, and variceal bleeding occurs at a higher gradient, usually 12 millimeters of mercury. There are many causes of portal hypertension. There are prehepatic causes, including portal vein thrombosis, extrinsic compression of the portal vein, congenital portal vein stenosis, arteriovenous fistula, and SVC obstruction. There's also hepatic sinusoidal causes, so intrahepatic. Most commonly that we see is cirrhosis, also viral hepatitis, schistosomiasis, congenital hepatic fibrosis, infiltrative liver disease, polycystic liver disease, nodular regenerative hyperplasia, idiopathic portal hypertension. And then last but not least, there's also post-hepatic causes, Budd-Chiari syndrome, sinusoidal obstruction syndrome, congestive cardiac failure, and constrictive pericarditis. So some findings related to portal hypertension that we can see on CT scan are collateral vessels and varices. There are a number of different locations where these can appear. I wanted to bring your attention to these gastric varices here because they can actually be quite symptomatic for patients. These can bleed even at very low pressure gradients. So those are some varices that can cause a lot of morbidity for patients. Here's another example of more varices here in the splenorenal area predominantly. And then more here in the mesentery you can see as well. Other CT findings, you can see contrast enhancement in a recanalized paraumbilical vein, which is usually pathognomonic actually for portal hypertension. You can see this large dilated venous structure here is a recanalized paraumbilical vein. Splenomegaly, you can see the dramatic size of the spleen here compared to the liver as another sign as well. And there are complications of portal hypertension, ascites, esophageal varices and gastric varices, and variceal bleeding, which carries a mortality of 30 to 50% with each bleed, portal hypertensive gastropathy, enteropathy, colopathy, also hepatic encephalopathy, hepatorenal syndrome, hepatopulmonary syndrome, and congestive splenomegaly and hypersplenism. The Child-Pugh score is an older scoring system, also known as the Child-Turcotte-Pugh or the Child score. It's a system for assessing the prognosis of chronic liver disease, primarily cirrhosis. It provides a forecast of the increasing severity of liver disease and expected survival rate. As you can see, it's made up of 5 different parameters. 3 are laboratory values, bilirubin, albumin, and INR. And then 2 are clinical, ascites, which I just realized is spelled incorrectly here, sorry, and encephalopathy. And then you can assign a point of 1, 2, or 3 based on how severe the symptom is. And then overall, you can look at overall survival in the different classes. So the low score, 5 to 6, is usually class A. It's a very good 1-year survival, but you get worsening survival rates with levels of decompensated cirrhosis. Treatment for this, you can start with lifestyle modifications, dietary sodium restriction, especially for ascites, medications such as propranolol or diuretics. And you can also use interventional procedures. So we can create shunts, namely the most common one you see is called a TIPS, transjugular intrahepatic portal systemic shunt. There are also DIPS, and there's also mesenteric direct shunts as well. You can do balloon dilatation of the hepatic vein. This is particularly done for Budd-Chiari syndrome. If there's thrombosis or a web in the hepatic vein, that can also help. You can do transhepatic clot thrombolysis for portal vein thrombosis. And you can also do splenic artery embolization, which takes the pressure head off. It helps decrease the amount of blood going through from the splenic artery to the splenic vein into the portal system. And you can also perform a liver transplant for these patients as well. This is a case demonstrating TIPS. You can see our pigtail marker going through, and this is a portal cavogram. You can see this dilated varices here, and which can be treated at the time of TIPS creation with coils here. Also, at the time of TIPS, you may see this finding. This is retrograde filling of a rectal vein going towards the rectum. And this patient had symptomatic variceal bleeding. And we can actually treat with gel foam and coil down there and help symptomatically relieve that bleeding in this area. Indications for TIPS, the most well-known are recurrent variceal bleeding and ascites refractory to medical management. So it's not, the first time someone presents with a variceal bleed. It's usually after a few episodes. It has to demonstrate that it's recurrent. And then the ascites also has to be refractory to medical management. You can also treat with for acute variceal bleeding when pharmacological therapy and endoscopic sclerotherapy have failed. Hepatic hydrothorax is another indication that if it cannot be adequately managed. Portal hypertensive gastropathy, hepatorenal syndrome, and lower gastrointestinal stromal varices. Also Budd-Chiari syndrome that's not responsive to anticoagulation. There are contraindications to TIPS that you should know as well. Some of these are relative contraindications and some are absolute. These include severe chronic liver disease or rapidly progressive acute liver failure, severe encephalopathy, severe right heart failure, uncontrolled sepsis, cavernous transformation of the portal vein, cystic hepatic disease, occlusive main portal vein thrombus, or hepatic malignancy or hemangioma. The MELD score is the model for end-stage liver disease, was developed in 2000 to predict mortality in patients undergoing TIPS creation. It's actually, interestingly, a formula that you plug in. So it's 3 laboratory values: bilirubin, creatinine, and INR. I had the chance to do this paper a while ago now, but we actually validated the MELD score for cases of emergent TIPS creation for variceal hemorrhage. So before that, it was usually validated only for the non-emergent TIPS, but this actually shows that it is still valid for the acute emergent TIPS creation as well. What we found is that there was a difference in survival based on MELD score. So typically patients with lower MELD score, usually 18 is a good cutoff here, shows improved 90-day mortality, whereas it really drops once you get above 19. Other things that we can discuss related to portal hypertension is gastric versus esophageal varices. So there's a nice paper that showed that gastric varices actually can bleed at lower pressure gradients. And so those are the ones that are more concerning. If you see those, that would be a bigger impetus to start talking about treatment for these patients. Hepatic encephalopathy is a known complication for TIPS. This was a paper I had the chance to work on as well, looking at the overall incidence. It was actually quite high, 42% in our cohort. But luckily only half was de novo. Half the patients had encephalopathy before TIPS. Usually occurred about 2 to 3 weeks post-TIPS in the de novo cases, and slightly earlier in patients who had a prior history. Cases were mostly mild or moderate and amenable to medical management. Only 4% of patients underwent TIPS reduction or occlusion in this cohort. Worse liver function and older patient age also contributed to hepatic encephalopathy after TIPS. BRTO is another treatment, balloon occluded retrograde transvenous ablation. This is usually performed in the absence of TIPS, so instead of a TIPS. And this is for treatment of gastric varices, particularly those with prominent portal systemic venous shunts. So you have to be able to find the shunt on the CT scan in order to target it for treatment. There's modified techniques, which include the vascular plug assisted retrograde transvenous ablation, the PARTO. You can also do CARTO with coils, or you could do balloon occluded retrograde, which is antegrade transvenous ablation called the BATO. There's a very high rate of technical success. Rebleeding rates range from 5 to 15%, and it may actually worsen the portal hypertension and other varices if they had esophageal varices or ascites or hydrothorax. And that's all I got.